1, 2,
And review 70-year-old female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people say? And her blood pressure is off the property.
45 minutes of CPR and no return of circulation. Okay.
Oh. Oh.
You are managing 2 patients, right? But you can only see one of them.
Yeah, that's exactly the reality of it.
Because when you think about it, I mean, most areas of medicine give you some level of diagnostic comfort. Like you break a femur, you get an x-ray, and you see that jagged white line right there.
Right, it's in black and white, it's binary.
Exactly. But you step into the world of obstetric nursing, you know, dealing with fetal hemodynamics and maternal perfusion, and suddenly you're basically flying on instruments.
You really are. The visual luxury is just stripped away.
It's a landscape that is murky and dynamic, and the stakes are incredibly high. So, welcome to this clinical edition of the Deep Dive.
Glad to be here for this one.
Today, we are tearing into the absolute highest stakes scenarios in OB nursing. I mean, from the microscopic fragility of week 5 embryogenesis all the way to the triage protocols that stop a mother from bleeding out.
Yeah, we're shifting out of passive reading mode today.
Straight into clinical mentorship mode.
Yeah.
We've got a massive stack of intense obstetric sources, but we aren't just reading facts.
No, we have to act as your elite clinical educators today. What's fascinating and honestly demanding about OB nursing is you frequently have 2 patients with totally competing physiological needs.
Right. What saves the mom might harm the baby.
Exactly. So our mission today is to sift through this material using the Pareto principle. We are finding that 20% of high-yield info that gives you 80% of the value.
For your nursing exams, sure, but mainly for your real-world clinical judgment.
Because that's what keeps patients safe.
Absolutely. We're going to cover the ABCs of OB nursing, prioritize interventions, avoid those nasty NCL-EX traps, and deeply understand the why behind maternal and fetal safety.
Because just memorizing a list of symptoms, that won't save a patient crashing in triage.
No, it won't. You need to know the underlying hemodynamics. But real quick, before we dive into the clinical weeds, we do need to establish a strict baseline of neutrality here.
Yes, that is vital. When we discuss topics like abortion today, our focus is 100% on factual clinical nursing management.
Just the science and the safety.
Right. It's about maternal safety, pharmacology, and the objective source material. This is entirely devoid of any political stance.
Our only allegiance is to patient safety and competent nursing care.
Always.
Okay, so let's get into section 1, the life support system. We have to start with embryogenesis, the placenta, and the amniotic fluid.
Because before you can monitor a fetus, you have to understand the structures keeping it alive.
Right. You can't fix fetal distress on a monitor if you don't know the supply chain. And I actually like to compare the early blastocyst to a NASA space capsule.
Oh, I like that analogy.
Yeah. Think about the modules you need to keep an astronaut alive. The yolk sac is like the initial ration pack, right? It gives early nutrition before the placenta takes over.
Right, and it handles early red blood cell formation.
Exactly. Then the allantois is the exhaust system handling early waste. The amnion is the pressurized habitat. And then the chorion is the heavy-duty communication array.
The chorionic villi literally burrows into the uterine lining to build the placenta.
It's wild. So let's translate that into our high-yield core. For exams, timing is everything, right?
It really is. So fertilization happens in week 3 of a typical 28-day cycle. Implantation at week 4 ends the pre-embryonic period.
Okay, week 4.
And then week 5 marks the start of the embryonic period, which runs through week 10.
And I want to pause there because weeks 5 through 10, that's the absolute danger zone, isn't it?
It is the single most critical window. The cells are undergoing massive differentiation.
Like organogenesis.
Exactly. The neural tube is closing, rudimentary heart tubes are folding. It's a furious pace, making it the highest risk window for teratogen-induced birth defects.
So to clarify the mechanism, a teratogen is an environmental agent, right? Like illicit drugs, or a virus like Zika.
Yeah, or alcohol or ionizing radiation.
So if a patient gets exposed to a teratogen at week 12, the risk of missing a limb is actually lower than at week 7.
Precisely. Because by week 11, you're in the fetal period. The major architectural structures are already there.
So they're just maturing and growing?
Right, so a week 12 exposure might cause growth restriction. But week 5 to 10 is your hypervigilant teratogen window for major structural anomalies.
Okay, that makes sense. Let's pivot to the lifeline itself, the umbilical cord.
Oh, this is a classic area where nursing students get totally turned around.
Because of the arteries and veins, right?
Yes, the umbilical cord has 2 arteries and 1 vein, but the hemodynamics are completely backward compared to an adult.
I remember fighting with this in school. Like, why call it an artery if it has deoxygenated blood?
Because anatomically, an artery just carries blood away from the heart.
Right. Regardless of oxygen.
Exactly. The fetal heart pumps blood away from itself out to the placenta through those 2 umbilical arteries. And that blood is full of waste and CO2.
Because the placenta is acting as the lungs and kidneys.
Right. So once the placenta exchanges gases with the mom, that fresh, highly oxygenated blood returns to the fetal heart via the single umbilical vein.
2 arteries carrying waste away, 1 vein carrying oxygen back.
So important.
Which brings us to why it matters. Why does the bedside nurse need to care so much about this vascular structure?
Because while the placenta is a biological marvel, it is not an invincible shield.
The mom's blood and baby's blood don't directly mix normally.
Right, they're separated by a micro-thin layer. Oxygen and antibodies cross over beautifully, but harmful things can hitch a ride.
Like live viruses or anti-RH antibodies.
Exactly, and clinically, we care deeply about where this placenta implants. Normal is high up in the uterine fundus.
But if it implants in the lower segment, over the cervix, that's placenta previa.
And that is a top-tier exam priority. Think about labor. The cervix has to thin out and dilate to 10 centimeters.
So if the placenta is planted right over that opening,
The moment the cervix stretches, those blood vessels shear and tear apart.
which presents as painless, bright red vaginal bleeding. And as a nurse, if you see that in the 3rd trimester, you never ever perform a digital vaginal exam.
Never. You could punch right through the placenta and cause a fatal hemorrhage in minutes.
Okay, let's clearly separate the expected versus concerning findings here.
Expected finding number 1. Amniotic fluid changes drastically. Early on, it's basically maternal serum. But around week 11, the fetal kidneys kick in.
The fetus swallows the fluid and pees it out, right?
Basically, yeah. So later in pregnancy, amniotic fluid is overwhelmingly fetal urine and lung secretions.
It sounds gross, but it's sterile and totally expected. And fluid volume tells us a lot about fetal hemodynamics.
It really does. It's a shock absorber for the cord. Another expected finding is the cord inserting right into the center of the placenta.
So what's a concerning finding there?
Abnormal cord insertion, like a velamentous insertion where the blood vessels separate before reaching the placenta.
Meaning they're running unprotected through the membranes.
Exactly. Normally, they're encased in Wharton's jelly, which is like biological bubble wrap,
But without it, they're exposed.
and highly susceptible to tearing. If the membranes rupture, the fetus can literally exsanguinate in utero. It's terrifying.
Which transitions us to priority nursing actions. We're rigorously monitoring the amniotic fluid index, the AFI, right?
Yes. Too much fluid is polyhydramnios. Too little is oligohydramnios.
And when I see oligohydramnios, my brain immediately thinks fetal kidneys and cord compression.
That is the exact clinical judgment you need. If fluid is mostly urine and there's no fluid,
Yeah.
you have to ask if the fetal kidneys are failing or if the placenta is failing to deliver blood.
Right, because the fetus shunts blood away from non-essential organs like kidneys to protect its brain.
Less blood to kidneys equals less urine, which equals oligohydramnios, and huge risk for cord compression.
Okay, top exam traps for this section. Test writers love these.
The highest yield trap is the oxygenation of the umbilical vessels. Do not use adult anatomy. The single umbilical vein carries the oxygenated blood, not the arteries.
Got it. And the timeline trap.
Yeah, they'll ask about a teratogen exposure at week 8 versus week 28, which is higher risk for a missing organ.
Week 8 because it's in the embryonic organogenesis period. Let's lock this in with a memory anchor. The acronym AVA. AVA, artery, vein, artery.
2 arteries, 1 vein. And vein is a shorter word, so it carries the single most important thing, oxygen.
I love it. Okay, if you only remember 5 things from section 1. 1, embryonic period, weeks 5 to 10 is peak teratogen danger. 2, AVA, 2 arteries, 1 vein. 3, the single vein is oxygenated.
4, placenta previa is low-lying, painless bleeding, no digital exams.
And 5, fetal urine makes up amniotic fluid later on, indicating renal and placental perfusion.
Excellent. That builds our foundation for section 2, fetal milestones.
Right. Now that the hardware is hooked up, how does the fetus develop? And when can it survive outside the womb?
Viability. It's a heavy concept.
It is.
Yeah.
And I have to ask, we just said the placenta does all the breathing in utero. The fetal lungs are offline. So why is OB nursing so obsessively focused on fetal lung development?
Because the moment of birth is the most extreme hemodynamic change a human will ever experience.
The umbilical cord gets clamped?
Yes, and systemic resistance skyrockets. The baby takes its first gasp and has to force fluid out of the alveoli and fill them with air.
If the lungs aren't prepared, the baby suffocates.
Exactly. Which brings us to the high-yield core. The cardiovascular system is the first to develop.
Because diffusion isn't enough anymore, it needs a pump.
Right. It beats by week 6 or 7, around 110 to 120 beats per minute. But a beating heart doesn't mean viability.
So what's the threshold?
A fetus born before 23 weeks has about a 5% survival rate. But by 27 weeks, survival skyrockets to 94%.
That's a staggering jump in 4 weeks.
And the sole reason is pulmonary surfactant.
Surfactant, the microscopic soapy substance.
Yeah. Think of alveoli like wet plastic bags.
Yeah.
The surface tension makes them stick together tightly.
So you'd have to blow incredibly hard to open them.
Exactly what happens in a fetal lung without surfactant. It coats the alveoli, reduces surface tension, and stops them from collapsing when the baby exhales.
Without it, you get atelectasis and respiratory distress syndrome.
And the timeline is highly testable. It starts being produced at week 24.
But it isn't sufficient until week 32.
Right. Which dictates why it matters. If a patient comes to triage in active premature labor at 28 weeks, what's your clinical judgment?
Well, they have some surfactant because it's past 24 weeks, but not enough because it's before 32.
Exactly. So your priority actions are alerting the NICU to prep a ventilator and anticipating an order for a maternal intramuscular corticosteroid.
Like betamethasone. We give the steroid to the mom, it crosses the placenta, and it artificially stresses the fetus to rapidly accelerate surfactant production.
We are chemically forcing the lungs to mature faster. It's brilliant.
Okay, let's contrast expected versus concerning findings. Expected fetal circulation is all about bypassing the lungs and liver, right?
Yes. The fetus uses 3 shunts. First, oxygenated blood from the umbilical vein bypasses the liver via the ductus venosus.
Dumping straight into the inferior vena cava.
Then it hits the right atrium. But the fetal lungs are full of fluid, creating immense pressure.
So the blood takes the path of least resistance.
It shoots across the atrial septum through the foramen oval, straight to the left atrium. That's the second shunt.
And any blood that does trickle to the right ventricle and pulmonary artery?
Gets caught by the third shunt, the ductus arteriosus, which connects directly to the descending aorta.
It's an overflow valve bypassing the lungs. It's amazing.
And when the baby is born and takes a breath, pulmonary pressure drops, and all 3 shunts functionally slam shut.
Wow. Other expected milestones? Neural tube closes by week 4, mother feels quickening or movement by week 19.
So what are the concerning findings?
Absent heart rate by Doppler after week 12. Or a mother reporting decreased fetal movement. If she felt kicks at 19 weeks and then nothing for 2 days at 24 weeks, that is an emergency.
An immediate clinical priority to rule out hypoxia.
Let's hit the top exam traps for milestones.
Instructors will describe an ultrasound at week 12 showing fetal breathing movements and ask what's happening.
And the trap is choosing gas exchange.
Yes, gas exchange is physically impossible at week 12. The fetus is just doing a diaphragmatic workout, pulling fluid in and out to develop the chest wall. Oxygen is still 100% from the placenta.
Okay, memory anchor for surfactant. I love this one. 24 to pour, 32 to do.
Yes, Porzen at 24 weeks can actually do the job at 32 weeks.
Okay, our 5 takeaways for section 2. 1. Cardio system develops first. 2. 3 shunts bypass the lungs and liver.
3. 24 to pour. 4. 32 to do.
And 5. Quickening by week 19 and decreased movement is an emergency.
Outstanding. This leads us into section 3. Spontaneous abortion or miscarriage.
This is where clinical precision meets deep empathy. People use the word miscarriage as a blanket term, but clinically there are 5 distinct types we have to triage.
Right, the high-yield core. Spontaneous abortion is a loss before 20 weeks. Incidence is 9 to 17% in your 20s, but jumps to 80% at age 45.
Most commonly due to chromosomal abnormalities.
Yes. So let's break down the classifications. We have to look at the cervix, the muscular gatekeeper of the uterus.
A complete abortion is cramping, bleeding, and the uterus is completely empty. The gate is closed.
An incomplete abortion has heavy bleeding, the gate is open, but only a portion of the tissue passed. Retained fragments cause continuous hemorrhage.
And the big exam focus. Threatened versus inevitable.
A threatened abortion presents with mild cramping and spotting, but the cervical os is closed tightly. The ultrasound shows a heartbeat. The pregnancy is threatened, but intact.
Contrast that with an inevitable abortion.
The bleeding is heavier, but the defining feature is the cervix is visibly dilated. The gate is open, so the process cannot be stopped.
And finally, the missed abortion, which is silent. No bleeding, closed cervix, but the fetus has died in utero. Pregnancy symptoms just fade away.
Moving to why it matters. Any vaginal bleeding in the first trimester is a medical emergency until proven otherwise.
Because we have to rule out an ectopic pregnancy, the #1 cause of first trimester maternal mortality.
Ectopic pregnancy is when the blastocyst implants outside the uterus, 90% of the time in the fallopian tube.
And the tube can't stretch like the uterus.
No, it's a fragile, narrow corridor. As the embryo grows, the tube stretches to its breaking point and ruptures.
Tearing open major blood vessels, the mother hemorrhages internally, sudden stabbing abdominal pain, referred shoulder pain.
Her blood pressure drops, heart rate spikes, hypovolemic shock. She needs emergency surgery immediately.
So ruling out ectopic via ultrasound is the absolute priority.
Which highlights our expected versus concerning findings. Threatened abortion with stable vitals is expected. Ectopic rupture is concerning.
Also concerning, massive external hemorrhage, saturating more than 1 to 2 pads per hour for 2 consecutive hours.
So priority nursing actions, 2 large bore IVs, type and cross-match. And then the critical medication action, RhoGAM.
Yes, alloimmunization. If a mom is Rh negative and the fetus is Rh positive.
During a miscarriage or delivery, fetal blood can cross into the mom's bloodstream. Her immune system sees the Rh positive cells as invaders and makes antibodies.
The first antibodies are IgM, which are too big to cross the placenta, so the current pregnancy is fine.
But the body makes IgG antibodies for memory, and those can cross the placenta.
So in a future pregnancy with an Rh positive fetus, those antibodies attack the fetus's red blood cells, causing erythroblastosis fetalis, heart failure, fetal death.
It's devastating and entirely preventable. We administer RhoGAM within 72 hours of any bleeding event.
It acts like an invisibility cloak, right?
Exactly. It binds to the fetal cells so the mom's immune system never sees them. You save her future pregnancies.
Okay, top exam traps here.
Examiners give a scenario of bleeding at 8 weeks and ask for the diagnosis. Look at the cervix in the prompt. Threatened equals closed. Inevitable equals open.
And the trap with the missed abortion is thinking there has to be bleeding. There isn't.
Right. Memory anchor. Visualize a door. Threatened abortion, the door is closed. The baby is safe behind it. Inevitable, the door is open. The loss is going to happen.
Love that. The 5 takeaways for Section 3. 1. Rule out ectopic first. 2. Give RhoGAM within 72 hours if Rh negative.
3. Threatened is closed. Inevitable is open. 4. Track pad count strictly. More than 1 to 2 an hour is danger.
And 5. NSAIDs like ibuprofen are contraindicated in pregnancy. Use acetaminophen.
Excellent. Let's move to Section 4. Medical and procedural abortion.
Returning the uterus to a non-pregnant state carries identical maternal risks, regardless of why it's being emptied.
Right, because the myometrium, the uterine muscle, is a woven basket of fibers. The blood vessels weave through it.
So when the uterus empties, the whole thing forcefully contracts to pinch those vessels shut, living ligatures.
But if there's anything left inside, like routine tissue or clots, it acts like a doorstop. The muscle can't clamp down.
The vessels stay open and you get catastrophic hemorrhage.
So for medical abortions, we use the 2-step medication regimen, mifepristone first.
Which is an antiprogestin. It blocks progesterone, the hormone that maintains the uterine lining.
Without it, the lining breaks down and the embryo detaches, unplugging the life support.
Then, 24 to 48 hours later, misoprostol.
A synthetic prostaglandin. It violently contracts the smooth muscle to physically expel the tissue.
Why? It matters. The nurse is the first line of defense against hemorrhage and sepsis.
Expected findings after misoprostol: heavy cramping, bleeding, passing clots, also nausea, temporary fever, chills.
Spotting can safely continue for 4 weeks.
But the concerning findings make up the post-abortion triad.
Severe pain not relieved by meds, heavy hemorrhage, and a persistent fever.
That indicates retained products and a brewing infection.
Priority actions. Assess vital signs for hypovolemic shock and strict discharge teaching.
Teach them the pad rule. Soaking more than 2 pads in 2 hours is an emergency. Purulent discharge is an emergency.
Top exam traps. Pain management. You tell them to take acetaminophen, but avoid what?
Aspirin. Do not take aspirin. It irreversibly inhibits KOX1, making it a powerful antiplatelet drug.
It stops clots from forming. If they take it while the uterus is trying to heal, they exponentially increase bleeding risks.
Another trap. Suspected ectopic pregnancy is an absolute contraindication for these meds.
Because misoprostol contracts the uterus, which does nothing for a blastocyst stuck in the fallopian tube. It'll just rupture.
Exactly. Memory anchor. Mifepristone blocks the hormones. Misoprostol moves the uterus. Blocks and moves.
Our 5 takeaways for Section 4. 1. Mifepristone blocks, misoprostol moves. 2. Retained products act like a doorstop. 3. Suspected ectopic is a contraindication.
4. Watch the triad of pain, bleeding, fever. 5. Teach patients to avoid aspirin.
Now for our final incredibly difficult section. Section 5, intrauterine fetal demise or IUFD stillbirth.
This is loss occurring after 20 weeks of gestation. It's a profound shift in clinical focus.
A mother at 36 weeks says she hasn't felt the baby kick. Your brain has to split into 2 tracks, rapid clinical assessment and psychological safety net.
The high-yield core causes can be placental abruption, severe diabetes, growth restriction, but presentation is just decreased fetal movement.
Why? It matters physiologically. If a deceased fetus stays in utero, the decaying tissue releases massive amounts of thromboplastin into the mom's circulation.
And that triggers DIC, disseminated intravascular coagulation.
Walk us through this. It's so counterintuitive.
It is a catastrophic failure of the coagulation system. The mom's body thinks she's bleeding everywhere, so it forms millions of microscopic clots internally.
Lodging in the kidneys and lungs.
But in doing so, it consumes every available platelet and clotting factor. It's a consumption coagulopathy.
So she has 0 clotting factors left.
And she begins hemorrhaging externally, oozing from IV sites, gums, massive uterine bleeding. She bleeds to death because she clotted too much.
Which dictates our expected versus concerning findings. If labs are normal, she has the luxury of time to grieve and schedule an induction.
But concerning findings: dropping platelets, plummeting fibrinogen, elevated D-dimer, she's slipping into DIC, immediate delivery is mandated.
Priority nursing actions. That mom in triage, what's your first physical action?
Assess fetal heart tones immediately with a Doppler. And be careful not to pick up the maternal pulse.
If you can't find it, notify the provider for a bedside ultrasound to definitively confirm.
Then track 2 takes over. Empathic, structured care, no empty platitudes.
You use the baby's chosen name. You create a memory box with footprints, a lock of hair. You don't rush this.
And postpartum placement is crucial. Place the mother on a medical surgical floor, not the maternity unit.
You can't have her listening to crying newborns all night.
It's psychological torture.
Now, the massive top exam trap here, delivery method.
Students see an IUFD and think emergency C-section.
But a C-section is the exact wrong answer.
It is contraindicated unless there's another emergency. Think about DIC. If you cut open her highly vascular abdomen when she can't clot, she will bleed to death on the table.
Even if she's begging to be put to sleep, the safest evidence-based route is induction for vaginal birth.
It minimizes blood loss and preserves future reproductive health.
Memory anchor. The 4 L's. Listen, look, labor, love.
Listen with the Doppler, look with the ultrasound, labor via induction, and love through psychosocial care.
Listen, look, labor, love. Our 5 takeaways for Section 5. 1. First action is Doppler assessment. 2. IUFD is loss after 20 weeks.
3. Monitor vigilantly for DIC. Watch for spontaneous bleeding.
4. Vaginal birth is clinically safest. 5. Provide memory boxes and place the patient off the maternity ward.
We have covered so much dense pathophysiology today.
We really have.
Right.
From AVA vessels and beta-methazone mechanics to the doorstop analogy of retained tissue and the terror of DIC.
Mastering this transitions you from memorizing lists to anticipating crises.
Because you understand the physiological why behind the what.
And I want to leave you with a final clinical reflection. Think about the placenta. It is a temporary disposable organ.
Right?
Yet it acts as the fetus's lungs, liver, kidneys, and immune system all at once. When we look at complications, previa, oligohydramnios, DIC, they almost all trace back to the health of this temporary organ.
It's the root of so much pathology.
Exactly. If you want to master OB nursing, don't just study the mother, don't just study the baby. Study the bridge that connects them.
Study the bridge between them. What a perfect framework. In triage, you're managing those 2 interconnected lives without the luxury of an X-ray. But armed with this hemodynamic understanding, you can navigate it safely.
Absolutely.
Keep reviewing those milestones. Keep asking the why behind the mechanisms and bring this clinical judgment to your next exam and your future patients. Stay vigilant out there.